Hi, everyone. We are here at another Tuesday. My name is Dr. Tofi. Welcome to Hernia Talk Live. As you know, every Tuesday we have this awesome session. It's an hour with one of my favorite people, and it's currently being simulcast on Zoom and Facebook Live. You can also follow me on Twitter and Instagram at Hernia Doc. And once we're done, I will make sure that I post the entirety of this live session on my YouTube channel. Today's guest is Dr. Edna Ma. Dr. Ma is a superstar. She is a board certified anesthesiologist. You can follow her on Facebook at Dr. Edna Ma. And if you do so, you're going to find some really interesting things about her, which we will discuss towards the end of this hour. But first, I'd like to welcome Dr. Ma. Hi.
Thank you, Dr. Tofi, for having me. It's so exciting to see you.
Thanks so much for coming and giving me your time. And I just want to make sure that we're very respectful of your time. Dr. Ma is an anesthesiologist. She's married to a surgeon. She has 2 children who will probably, I don't know, will they be doctors as well?
Who knows? You know, I did, my little one, she seems to be interested in doing medicine. She was, before the pandemic, she would wear one of the surgical masks around the house. And so who knows, she enjoys the whole doctoring thing and the stethoscope and everything.
That's very cute. Do you ever dress them up for Halloween?
Yeah, I do. And they're very reluctant Halloween kids.
It's like the easiest thing. You just grab like a mask and cap and everything.
Exactly. Pretty easy.
So Dr. Anesthesiologist is our anesthesiologist. If you come and have surgery with me, most likely you will meet her. She's also a superstar. She's an entrepreneur. She's a book writer, author. She's multilingual.
You're embarrassing me. You're embarrassing me now.
She's kind of survived on an island for a long time, for a while. We'll get all onto that, but just really briefly, what got you involved in anesthesia? And how much do you love my patients?
Well, I need a whole Facebook Live session just for how much I love working with you. Well, I always knew I wanted to be a physician, and I thought I wanted to be an internal medicine doctor. But then as you rotate through medical school and you get exposed to different specialties, you realize how much more interactive it can be with in the operating room. And I really liked kind of being the internal medicine doctor in the operating room. And we do procedures too in anesthesia. At the time I graduated, it was just the very, very beginning of ultrasound guided regional anesthesia was becoming more standard of care. Now it's become the mainstream in terms of adjuncts to general anesthesia and sedation anesthesia. There's a lot more involved procedures that we do in anesthesia now.
So as all of you know, I do hernia surgery, but I do open surgery, laparoscopic, robotic. I have patients that are totally healthy and have no problems. And I have patients with severe chronic pain, and treating them from an anesthetic standpoint is very different. And the type of surgery I do requires different amounts and degrees of anesthesia. So it's really great and helpful to have an anesthesiologist who's aware of all that. In the United States, most hernia surgery is done under general anesthesia. It's not common. It's totally doable, but it's not common to do hernia surgery under local anesthesia alone with IV sedation. And we'll go into that a little bit, but maybe Dr. Ma, you can answer our first question, which is, what are the different types of anesthesia for hernia surgery?
Okay, and I'll kind of talk about types of anesthesia in general, and then I'll kind of narrow it down for hernia surgery. Yeah. So anesthesia there's just, I would say, 3 broad categories, maybe 4 broad categories, depending on how there's a lot of overlap, like a Venn diagram. First, there's general anesthesia, and usually that involves being completely unconscious, and usually involves a breathing tube that's placed after you're asleep and comes out usually when you're asleep. So you're completely asleep. This is like I kind of compare it to consciousness to like a light dimmer. So you're completely awake, the lights are bright and fully on, and then there's like completely off where the switch is off. But then you have like a dimmer, so all that stuff in between, kind of you're awake but not really awake, and you're kind of in that gray area. So general anesthesia is completely asleep. Then you have, usually with a breathing tube, and then you have sedation anesthesia. Sometimes it's referred to as twilight anesthesia or monitored anesthesia care, MAC anesthesia. And that even within MAC anesthesia can be completely aware, like sedation for cataract surgery, where you need your cooperation to open your eyes and look at the light, and you need to be awake enough so your eye is facing forward. So that's also considered twilight or MAC anesthesia. But then you have kind of deeper anesthesia, which is still considered twilight MAC anesthesia, that's given for like a colonoscopy, but you're still breathing on your own, no breathing tube, and you may be a lot more unconscious or unaware of what's going on for that type of sedation. So that's
Right.
kind of the description for the consciousness level of control. Then we have regional anesthesia, and that can be divided into two subcategories: neuroaxial, which is like spinals and epidurals, and then you have regional anesthesia in terms of isolating a limb or part of the body for depositing local anesthesia. And specifically with hernia surgery, a lot of regional anesthesia involving the abdominal wall is becoming more common, especially in Dr. Tofai's practice. And there's a lot of benefits for that. You want me to go into that?
Sure.
Okay, so the regional blocks that are relative to hernia surgery, that includes truncal blocks. That would be like a they call it a tap block. I'm pushing myself back so I can kind of point to my body. A tap block, which is transverse abdominis plane. I don't know if maybe I can show you a picture. Everybody's abdominal wall consists of 3 layers of muscle. And I'm gonna just pull up what I have. I have a little file inside my iPhone. I don't know if you can see that.
Yep.
So it is.
Yep, that's good.
It's a schematic, a cross section of everybody's body. And we use an ultrasound to identify the layers of the muscle, and everybody's nerve fibers kind of land in the certain layer. And with the ultrasound, we use just the same ultrasound that we use for identifying the gender of a baby. So it's not harmful, it's not invasive. Identify those layers and deposit local anesthesia. And this is even becoming so common that people having C-sections are having this type of anesthetic placed after their C-section.
Yeah.
The benefits of this is that you can avoid opioids or narcotics, and opioids can be anything from like tablets that you take of Vicodin, Percocet, or IV morphine, or cousins of morphine. And there's a lot of benefits to avoiding those opioids, especially for hernia surgeries.
Yeah. So I think in general, the way that I look at it, typically the laparoscopic or robotic surgery, you need some relaxation of the muscles to expand the abdomen with the gas we put in, the carbon dioxide. And that tends to be very uncomfortable for patients if they're not completely put to sleep. So they get general anesthesia. Although there have been reports of doing it under spinal or even sedation, but that's not standard. Standard is general anesthesia for all the laparoscopic and robotic surgeries. And then for the open surgeries of the groin, not for the belly, for the groin, those can be done with any type of anesthesia, even no anesthesia. I mean, if you have, I operate on a lot of the transplant patients, or the people that are waiting transplant. So Cedars is the #1 heart transplant center in the world. That's a hospital I work out of. And so there are a lot of patients waiting on the wait list to get their heart transplant, which means their heart's currently not functioning well. And those are like the worst patients to give anesthesia to. And so I can do surgery with just local anesthesia like lidocaine, with no anesthesia or very minimal anesthesia. So that's the other extreme. And then like maybe a little belly button hernia surgery, I can do that without general anesthesia because that's not a lot of stress on the body. But the big abdominal wall reconstructions, you really need the muscle relaxation that you get with general anesthesia. So
Absolutely.
There's a question already up, but I'm going to discuss that in a second once we talk a little bit more about general anesthesia. But what are the risks of general anesthesia? Because a lot of people are afraid of it. And many people don't want surgery because they're told they need to have general anesthesia. And so they're actually more afraid of the anesthesia than the operation. So what are the real risks of general anesthesia in modern day medicine?
Okay, So I would say that for most patients coming in for like elective outpatient hernia surgery are at very, very, very low risk for any serious badness, bad outcomes. I just want to say that kind of a general, because anything from heart attack, death, stroke, those are the things that I would consider very bad.
Right.
So, and for general and for your type of surgeries, outpatient surgery for hernias, that is extremely, extremely low. And I found some statistics, and everything is customized to the individual patient depending on their other comorbidities.
Yes.
Anesthesia these days is extremely safe. So statistically speaking, getting into your own car and driving to the hospital or the surgery center on the day of surgery is riskier to you than receiving general anesthesia. And as of like 2020, the mortality in the United States for like bad things like heart attack, death, stroke, that type of thing is 1.1 person in 1 million per year of anesthetics that are given. Less than 1.1 person. I don't know how they divided 1.1 person per million per year. So that's extremely, extremely low. And I think that anesthesia kind of got a bad reputation, if you will, maybe back in the 70s or 80s before modern medicines were introduced, before modern monitoring was employed. It wasn't until like the 1980s until the pulse oximeter became standard of care in the operating room. So this is like relatively recent history, right? And so even back in the 1990s, it was the risk of having something seriously bad happen to you during under general anesthesia is 1 in 100,000, and that's still
10 times higher than now.
10 times higher. But now we're talking in like basically 1 in 1 million per year.
It's not zero, but it's very, very low.
Very, very, very low. And you know what? Every one of your patients, especially one of your patients, you are the most organized office, Dr. Tofai. You have a checklist. You know, this is your patient here, decision tree and labs, EKG, all the workup, internal medicine optimization, because we have everything teed up. We don't want to try to figure it out on the day of surgery.
Right.
So, and all those things reduce the patient's risk for bad things happening.
So one thing people are afraid of is that they're going to wake up in the middle of surgery and kind of either feel what's happening or at least be aware of what's happening. There have been stories of people seeing their surgery be done or being able to recount what the doctor was saying about like their golf game or something during surgery.
Yeah, that wouldn't be us because we don't golf. But yes, golf. I hear you.
We'll talk about like our reality shows. But
yes, this is called awareness under anesthesia.
Yes.
And that it's all comers in terms of awareness anesthesia. It's about 1 in 10,000. So that includes like sedation anesthesia, general anesthesia, cardiac patients. So the patients who are highest risk for awareness under anesthesia are the people who you cannot give very much anesthesia to. So those are cardiac patients who cannot tolerate a lot of anesthesia. So maybe somebody who's on bypass or that heart transplant that you're kind of referring to. Patients who were in a traumatic injury, like a true trauma injury, where any sort of anesthetic can compromise their blood pressure and perfusion to their vital organs, brain, heart, that type of thing. So those are the patients who are at highest risk. Patients like coming on in a day of surgery, normal, healthy, optimized, very, 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 very unlikely.
And don't they have these like little EEG monitors nowadays where you can follow the brain waves?
They do have those. They're called a BIS monitor. There are some physicians, they use them more for like neurosurgery cases where they're trying to map or trace the EEG, the electrical activity in your brain. But that's actually not considered the standard of care to use a BIS monitor because they haven't been shown to be reliable. And so the other standard of care monitors like heart rate, blood pressure, is more predictive of awareness.
So I don't like to rely on general anesthesia if I don't have to. What I understand is it's actually easier for the anesthesiologist to maintain a patient under general anesthesia because you have full control of everything, and especially the airway.
Mhm.
Whereas with IV sedation, the anesthesiologist is much more involved to make sure that the patient's breathing and the blood pressures are under good control, et cetera. But I do prefer like sedation. I feel that after surgery, the patients are a bit more awake and they kind of come out of anesthesia much quicker if they don't get general anesthesia, if they just get sedation, IV, which is like propofol, right?
Mhm.
I also feel, because we have a question about, uh, two questions actually,
Mhm.
about these risks. I feel that because of the kind of the more delicateness of IV sedation, the patients also don't have as much narcotics used. They're not as deep. And so urinary retention is less of a problem. And that's something we actually discussed with, Dr. David Josephson. He was on a couple weeks ago, or maybe last week, 2 weeks
Yes,
ago.
he's great.
And
Yes.
he's great urologist. And we discussed the issue of urinary retention. So if anyone has like questions about that, that's a great webinar to listen to. Hernia Talk 2 weeks ago with Dr. David Josephson. But if you don't give as much narcotics or as deep of general anesthesia, then the risk of you having like a weaker bladder or inability to urinate is also improved. Do you find that that's true?
I 100% agree with everything that you say. It does require a level of more vigilance and diligence on the anesthesia provider's part when you're providing sedation anesthesia, because the airway is not secured. You have to be constantly paying attention because any slight movement affects what you're doing in the surgical field. And we would only give general anesthesia if it's necessary for those procedures that you talked about. You need a large incision on the abdominal wall or optimizing the surgical field or view and keeping the patient safe. So in addition to, in terms of laparoscopic surgery, you have, in laparoscopic surgery, you insufflate the abdomen with carbon dioxide. And normal respiration, you cannot get rid of that carbon dioxide that quickly if you're breathing spontaneously on your own. So that's the reason why we give general anesthesia. But to your question regarding like urinary retention, the medications that we used for general anesthesia have these anticholinergic side effects, which is like the $5
Right.
word to say, can cause urinary retention. Those medications just make urinary retention more likely. And when you're giving deep IV sedation, you basically avoid those medications that can cause the urinary retention.
Got it.
So I would say it's a little bit, in addition to, I know you always try to, use every case is customized, and in your preference, I definitely have noticed that it is, you lean more towards sedation anesthesia, if at all possible, without compromising the patient's safety. For patients who are having urinary retention, kind of our approach for that would be if we have a patient that's like a male patient who has most likely a prostate that might be enlarged just given the age for a hernia surgery, or has a history of like document BPH or benign prostatic hypertrophy, we can pre-treat them with like a medication like Flomax that would relax the prostatic outlet or sphincter for that area. And during surgery, what we also do is minimize the IV fluids if they need to have general. That further reduces their chance, and avoid opioids. One thing that I didn't really touch on yet, and you're hinting at it and made me think of it, with general anesthesia, that breathing tube goes in, the breathing tube comes out. And with hernia surgery, in a lot of the cases that we do in the Beverly Hills area, you don't want anybody to cough. You don't want anybody to cough. You don't want anybody to test the integrity of your suture site. And so when you're doing deep IV sedation, you don't have that breathing tube. So you could still cough, but it's just probably less likely with that. So especially in my, with my care with Dr. Tofai's patient, I take extra precautions to make sure that that patient is not coughing at the end of surgery or later.
That's a big peeve of mine. So, and those of you that are close with me I cannot have my patient either cough, or the other term we use is buck. When the tube is in your throat, it's like you're gagging on it. So it's a fine line between waking up without the breathing tube in your mouth and breathing versus like waking up earlier than that and feeling the breathing tube and then trying to gag against it. So coughing and anything like gagging or what we call bucking causes, exerts a lot of abdominal pressure, a lot more than any furniture you can lift or child you can lift or weightlifting, whatever. That's nothing compared to really bad coughing, retching, vomiting.
Yes.
So yeah, so
So
one
one,
is that the coughing is a big deal, but this is another one question we just got, which is a live question, which is the issue with vomiting or nausea after anesthesia. How do you handle that?
okay, just to kind of close the loop on the coughing after surgery with your patients, specifically, but I do this with the majority of my patients, but with your patients, I make sure double check that we numb the back of the throat with what we call an LTA, a lidocaine tracheal anesthesia. And so
Okay.
while the patient's completely asleep and unconscious, as I'm inserting the breathing tube, I spray the back of the throat and into the trachea, local anesthesia, so that breathing tube, you don't feel it. And not all facilities or not all centers have that lidocaine tracheal anesthesia. And then in yours, especially with your cases and a lot of other cases, we don't want bucking, such as neurosurgery cases or plastic surgery cases when you don't want to increase the pressure, eye surgery as well. You usually run like a propofol infusion that tends to be less irritating to the airway versus anesthetic gases. The volatile gases like sevoflurane and desflurane, those tend to be very irritating and provokes people to want to cough. So I take those extra precautions.
Right.
The second, nausea and vomiting. Okay, so this is something, it's like one of my most favorite areas to talk about, if you will.
Yay.
I'll have to I'll have to send you the article that it's been a couple years since it's been published in Outpatient Surgery magazine, but I wrote an article about that. I use a multi-prong approach for treating anesthesia. There are a lot of receptors in the brains that cause nausea, which means it kind of translates into a lot of triggers that cause nausea, which means a lot of medications can be used for treating nausea. And also it means that nausea is very poorly understood. So, so for me, I have a personal story of having such bad nausea and vomiting that I ended up having a Mallory-Weiss tear, which is a tear in your esophagus.
Wow.
And just from a local anesthesia, I had like a little surgery on my arm when I was in high school. And so I have a very personal connection with this nausea and vomiting. I didn't receive any anesthesia. It was all local, done at a dermatologist office. Yeah. And I received narcotics after the procedure. And I got so bad, so much nausea that I ended up tearing my esophagus. So I take special care for the people who say they have nausea and vomiting. So in addition to your routine fasting, minimum 8 hours fasting before surgery, on the morning of admission, if you have a high risk, I usually put a motion sick patch on you. Okay. And that's like what you see people wearing. It's like a sticker or the size of a circular Band-Aid that's worn behind the ear. It's called a scopolamine patch. And it takes several hours for it to absorb into the skin, which is why we put it on before surgery. Then I use, if it's appropriate, a very generous IV hydration. Yeah. That helps kind of catch you up with the fluid deficit. Just being dehydrated in itself can cause you to be nauseated. Think about the last time you were on a window seat on a long flight and you didn't want to go to the toilet. Just like it gives you a headache, just makes you feel bad, right? So you just want to hydrate that person up as much as possible and get that going. Avoid narcotics, opioids, morphine specifically. It's really not so great for nausea. And I use Decadron, or that's been in the news lately due to COVID, and Reglan, if that's allowed, or metoclopramide. And those are, you can give Pepcid. Pepcid's great for people who have reflux. It doesn't have a really strong anti-emetic profile, but it's an extra cocktail I include just to ward off evil spirits.
Yeah, that's really important because you don't, besides the fact that you feel sick, you definitely don't want to be retching or vomiting.
Yes, that's worse. I think that's probably worse than that coughing after surgery, because it's more prolonged. You could be for hours or days. And the studies have shown that patients would rather have pain than they'd rather pay money to have pain rather than if they could avoid nausea and vomiting because it's so uncomfortable.
Yeah, I've heard stories of people who come to me with a hernia recurrence, and I always ask, "How was your recovery?" And they said, "Oh, uh, I was retching for 3 days."
Oh, that's
Some
terrible.
people got like like a pneumonia after surgery, and they ended up um, coughing. So all of these are factors for worse
Recurrence.
outcomes after your hernia repair, which is why it's important to kind of factor all
Oh,
that. Yeah.
the other thing I didn't say, but I should have said, was I avoid volatile anesthetics for those high risk for
Mm.
nausea patients. Propofol IV infusion has a lower risk for nausea and vomiting than the volatile anesthetics, or even something like Precedex. Now people are giving Precedex a lot, and that's the IV infusion.
Yeah. So I know that we're like saying how great IV sedation is, but I was told by an anesthesiologist that the IV sedation itself is not any less risky to the patient than general anesthesia. They consider the deep IV sedation that I require, as opposed to the IV sedation you get for colonoscopy, they consider that pretty much general anesthesia. Do you agree with that?
Okay, so I would say, okay, I kind of got confused about what the question was. Okay, your question is IV sedation any less risky to the patient than? No, so it's not less risky. And I feel like I have this conversation or answer this question every other day.
Yeah.
The research that were from the 70s that people have lingering in their mind that sedation anesthesia is safer than general anesthesia. It's so old, and um, it's been replaced with more modern studies that have shown with more modern anesthetics that are being used currently, and um, it's just shown not to be true. Sedation is not more safe than general anesthesia.
So like you're not less likely to have a heart attack.
That's right. You're
Heart
not
attack.
less likely. You're not less likely. And I would actually say that general anesthesia is safer than IV sedation in a lot of ways. So I don't know if you know that I do cases for dental surgeries and stuff.
Okay.
So and this is a whole separate ballgame when it comes to sedation for dental stuff. But you don't, that's surgery in the airway.
Yeah.
So and you can think of people who've had procedures in the airway who have had a bad outcome, like Joan Rivers, right? She had
Right.
so that she had sedation and she had laryngospasm and nobody made any intervention. When you do general anesthesia and anything regarding the airway, if you wanted to, if that's any concern, you put a breathing tube in there at the very beginning of the procedure, and that is like your seatbelt that you're wearing before driving into the Alps or whatever. That is your safety belt. So in that regard, general anesthesia is much safer than IV sedation.
Yeah, so I think to your life, safety to your life, like dying from it because you had a heart attack or there's a stress on the heart, the stress is pretty much the same with sedation versus general anesthesia because you're like knocked out,
When somebody is concerned about anesthesia, where the assumption is like sedation is safer than general anesthesia, I would kind of dig deeper. Like, what is the actual concern? Is it that they have $20,000 worth of veneers in their teeth that they don't want to have them damaged, or is it something related to maybe even malignant hyperthermia? They had a relative who had anesthesia. Like, there's usually something. But honestly, besides the breathing tube, you can run a sedation like a general anesthesia, like a sedation. You can put a breathing tube in, run propofol, but you just have that security of the seatbelt or the breathing tube in place. And other than that, it's pretty much identical to sedation anesthesia if you're talking about propofol only.
Okay, cool. We have another live question, which is, doing surgery in an outpatient surgery center versus a hospital, is it relatively riskier to do one versus the other? What's your thought on that? And I can give you my thought on that as well.
Okay, my thought right now for that is that surgery centers have been shown to be safer for patients receiving care that is appropriate for outpatient surgery center. If you're in one of those patients who are much sicker that maybe require post-operative care in the ICU or some sort of additional monitoring, then the hospital would be safer for you. And I'm just talking about that in general outside of COVID. Now, in COVID times, our patients are all tested for COVID before they come in,
Yes.
and our staff are checked routinely to make sure that they're healthy. So, and you don't cross paths with people who might be visiting a COVID patient or might be being admitted for a COVID patient. So I would say there's that part of it. And also there have been studies that show that your risk of having a hospital-acquired infection is much more reduced when you're having surgery in an outpatient center. I would say that those are my thoughts in general.
Yeah, you're right. I wasn't thinking of COVID. From a COVID standpoint, you're safer in an outpatient surgery center for the same operation. And you have less risk of surgical site infections usually in a lower volume surgery center than a higher volume hospital. That said, there are certain operations that must be done in a hospital setting. For example, you need, like right now, robotic surgery is pretty much done at the hospitals. There's no good robot in the surgery center. If I had one at the surgery center, I would do it at the surgery center.
I think you guys are working on it though.
We are.
Is that
We're working on it.
We're working on it. Stay tuned.
I don't know. You heard about it already. Okay.
I mean, everybody's talking about it.
Yeah, we're trying to pull some strings on that one. But my point is that so I personally, because I have such a close relationship with you all in my team, I personally prefer the surgery center for my patients if it's a good operation, good choice for them, because I have the same team. I have the same anesthesiologist. They know I mean, I never have to tell you, oh, don't give too much fluids. Oh, I need a tap block. Oh, make sure they don't gag or cough when you remove that tube. Like, it's done. It's automatic. My team is the same.
It's not reinventing the wheel with a
I'm
new
not
team at the
reinventing
hospital.
the wheel.
Mm-hmm.
But if my patient has really bad chronic pain issues, will need to be admitted overnight at least, or stay in the hospital, obviously I will do those in the hospital. My hospital of choice is Cedars-Sinai. It's like one of the top hospitals in the nation. But at the same time, they're really good at doing heart transplants and like major cancers and so on. So when I say, like, let me do this under sedation, they kind of look at me like,
Mm-hmm.
yeah, are you sure? Like, we can just do general. Like, no, yeah. I don't want general.
Let me get the level 1 transfuser here. Like,
it's like so overkill at the hospital. They're so overqualified for so much of what I need, that when I ask them for like a much more kind of lower end, more delicate anesthesia, it is like reinventing the wheel a little bit. And that's like among the top hospitals in the nation. So I love operating at Cedars. It's just most of the operations I do tend to be outpatient. Now the big abdominal wall reconstructions have to be done in the hospital. Robotics currently are all done in the hospital for the most part. And the chronic pain patients. So patient to patient, I think in some ways the outpatient surgery center is safer. But let me tell you, if your heart stops, or if you lose an airway or have some like dramatic allergic reaction to something, I think a hospital would be a safer place, because you had more people to like jump on you and figure it out, right?
Yeah, well, I would say that that being said, Cedars does a very good job with putting people in teams. Like, if you are going to be on the joint replacement team or the cardiac transplant team, that you generally have a rotation of providers, techs, surgical techs, anesthesiologists that work on that team. But that team is much bigger, let's say 15, 20 anesthesiologists that you may be rotating for your team, and they may be on like a knee replacement that day. So it's not like they're totally unaware of your system and your needs. But it's just more variables for a surgery like that. And of course you would never choose to have you'd choose the appropriate patient for the appropriate setting for the best outcome.
Yeah. And more surgeries are done as an outpatient. We had Dr. Ali Badi I think a month and a half ago,
Mhm,
and she does hysterectomies as an outpatient. The stuff that we
mhm,
used to do before as an inpatient, even hernias used to stay in the hospital for a week. Like all
mhm,
of that has been turned into outpatient. So I think
mhm.
that's kind of something that is evolving with time as well.
And I think that that can be seen across the board with all specialties,
Uh,
medicine, cardiology, anesthesia, the medications, all, and that makes, just echoing what you said, what we asked earlier regarding the safety of anesthesia. That just shows that. I mean, think about how it was before, taking out a gallbladder at the
yeah.
beginning of your internship year versus now we just do them outpatient.
I mean, my chronic pain patients, and the mesh removals that I do, I used to do them all at the hospital, but once I have like my own team at the surgery center, I do them all at the surgery center now.
Hmm.
So
Yep.
that's a nice kind of segue into this next question, which is about patients with chronic pain. So if you have someone who's been on opioids or has some very bad chronic pain syndrome, has a lot of needs for nerve pain, for example, is there a specific protocol you use during anesthesia to make sure they don't wake up in too much pain?
Yeah. So for that patient, I would speak to them the day before surgery and maybe even speak to the chronic pain doctor to have an idea and have a clear plan, and the surgeon to have a clear plan about what the anesthesia plan is. So
Yeah.
we would avoid opioids and use other adjuncts like ketamine or Precedex, and we would use keep that patient free from, or if this patient is trying to become free from opioids. This is what I'm kind of assuming. Is that what we're assuming? Or somebody who's on
Not
chronic opioids?
necessarily. These are people that are coming in with already a very high level of pain, so you don't have that much of a leeway. So usually, what we do is if they're on like a lot of narcotics or opioids, we
And they're
do
not trying to decrease their dose. What they're trying to
correct.
do is this. Okay. So what we would probably, in that situation, we would definitely talk to the patient, have an extensive kind of understanding of their pain dosing, because then you're talking about somebody who is constipated afterwards
Yeah,
and bearing down on their hernia repair.
yeah,
So we'd have to have a very good plan in terms of what the their outpatient pain doctor, the prescribing physician, what their regimen is, and in the operating room, come up with a plan
yeah.
to make sure their acute pain is addressed. And we would do that by using regional nerve blocks like we talked about, the
Mhm.
ultrasound guided tap blocks, and maybe even considered a indwelling catheter in that situation.
Yeah,
So it would be a one-time shot to direct the tip of the catheter, and then a tip of the needle and the catheter is threaded through, and a slow infusion of local anesthetic is given there. And we just don't want that patient afterwards. You can do a most fantastic surgery anesthetic, but post-operatively, if you're super constipated, that reverses any of the good work that you've done. Is that answering the question? Have I
yeah,
understood it?
absolutely.
Okay.
I heard about ketamine and magnesium. Are those also adjuncts?
Yes. So those are adjuncts to provide an opioid sparing. Everybody's
Mhm.
talking about this pandemic that we're having, the COVID pandemic, but there's actually still this other
Opioid crisis, yeah,
opioid crisis going on, and it actually is getting worse given that people are having a lot of uh, stress, physical, emotional, financial stress. So people are turning towards opioids just to kind of get themselves through life. And so that epidemic is still going on. And so we've taken advances or made certain protocols at our surgery center to do an opioid sparing approach. So whenever there's regional anesthesia that can be done, we provide that, what we've talked about specifically in your cases. And ketamine specifically is one of them, and that one's taking center stage again in a lot of different treatment modalities. And magnesium, those are all adjuncts in itself, and you just simple things like Tylenol as well, IV
yeah,
Tylenol and ketorolac, other non-steroidals, anti-inflammatory, all those things together come, not just by itself, are ways, are tools that we have to administer an opioid sparing anesthetic.
yeah,
And
and
you actually have a protocol too with your
yeah,
outpatient bromelain and inflammation protocol. Those things have, I mean, you have the research on that. to be
Yeah,
very
we're a big
effective.
fan of non-narcotic, non-opioid based pain management for those who are eligible for it, which is most people. And the reason for that is constipation is a big side effect of opioids, and it's also a huge enemy of the hernia repair.
I like that.
So vomiting, we already work here. So it's vomiting, retching, coughing, straining, which includes constipation. And so I try not to give any constipating medications, but the anesthesia can constipate the patient.
Mhm.
But I learned from you all about I didn't know there was such thing as non-narcotic anesthesia. You're the ones that taught it to me. I
Oh,
thought you had,
fascinating.
yeah,
It's like it's all the rage right now, you know?
it is. But that's
So
great. And I think it's important for patients to understand, like one of the reasons why we do this hernia talk is uh, I bring in people like you that are experts. I learn a lot. I change my practice from stuff that I learned from you all. And then the patients are empowered to go and talk to their anesthesiologist. Usually an anesthesiologist, if they don't see you, if they don't talk to you the night before, they will see you the day of surgery. And so these are questions to ask, like what kind of anesthesia am I going to get? I don't want to vomit or retch. I have a tendency towards constipation, or do we have to use narcotics or opioids? So these are all kind of really important topics to bring up and learn about. And I really appreciate that you share all this with us.
one thing about the non-narcotic, I would say I have taken care of patients. I said, this is our protocol. We do this opioid sparing, non-opioid anesthetic. And they're like, well, that's why you don't get any. I'm like, no, no, no. If you want some, I mean, if you feel like you need it, it's not like they're not available to you. It's like,
Right.
it's like the buffet in Vegas, which don't exist anymore, right? So it's like, if you want to have the dessert too, I mean, whatever it is, like, it's not that you don't get it at all, but if you wanted to have it, then it's there for you. So it's like, so some people, you can have the non-opioid sparing if that's what you prefer.
Because they still get the Tylenol, they still get the anti-inflammatory.
Yes.
You may not necessarily need the opioids.
Yes.
We already
They,
reviewed opioids.
they may not need it. That's the thing. But some people come in with the anxiety of saying, you're not going to give me any pain medicines. So that's not what we're saying. Where it is available if you need it and if you want it.
Yeah, but we already established opioids can cause constipation,
Yes.
nausea, vomiting, and urinary retention. So if you're prone to any of those, and it's not an operation that absolutely needs narcotics, then there you go. Okay, so the biggest question that people get stumped on is like, okay, so you said nothing to eat or drink for 8 hours. And what's the purpose of that? Why do they say that?
Okay, so there's a fairly high risk of nausea and vomiting associated with anesthesia. And
Okay.
we would rather have nothing in your stomach than, your double
Hamburger.
hamburgers, Big Mac. We don't have Big Macs for breakfast. I mean, what do you have at the International Pancake House? The pancakes in your or something like that. A McMuffin, that's it. You can't have a McMuffin in your lungs. That would be very dangerous. So that's the main reason why we have people fasting.
Yeah, because if you vomit and you're like knocked out, it'll go into your lungs.
Yes, there's only two places it could go, of the three places: back into your stomach, which is probably not going to happen, into your lungs, or out of your mouth. And
Yeah.
so because of that, we don't want you to end up with a aspiration pneumonia. So that's the main reason why you have to fast.
Can you talk about LMA? We have a question live about LMA, which stands for laryngeal mask airway.
Mm-hmm.
Is that safe, and does it increase or decrease risk of pneumonias
Aspiration.
or aspiration?
So an LMA is considered an advanced airway tool. It's like a breathing tube, but it sits on top of the vocal cords. And you don't need as much muscle relaxant to have that. I would put that in the category, if you can, if the surgery is appropriate for deep IV sedation, an LMA can be inserted. Most times when you are under deep anesthesia, most people can't tolerate an oral airway being placed in their mouth. Their gag reflex is relatively blunted at that point. If you can tolerate that, you can probably tolerate a laryngeal mask airway. And I mean,
why would you ever use an LMA?
For your kind of surgeries or in general?
Let's just talk about my surgeries. Why would you ever use it if you're either do IV sedation or the general endotracheal where it goes down your throat? Why would you choose the middle, which is LMA?
I would choose it if it was somebody who was a low aspiration risk. Let's say for somebody who doesn't, low aspiration risk for anesthesia means you don't have reflux, gastroesophageal reflux disease. So if you don't have that, and you have sort of like a higher risk for airway obstruction on your back. Let's say, for example, somebody who has sleep apnea. He's like, I always sleep on my side. So if you're sleeping on your back and the shape of your face, the anatomy of your face or your tongue, it's going to be obstructing it. Even with the oral airway in place, you would still be obstructing. Then those would be that type of person would be the
Like the
patient that would
loud
put an oral airway.
snores.
Yeah. Yeah. Because even you basically would have to be doing a jaw thrust the whole time, displacing the jaw anteriorly, leaning forward on the face to relieve that obstruction. And even loud snoring, it causes you to tug on your abdominal wall to get that breathing. So if somebody who has like sleep apnea that doesn't have reflux, I would put in that would be somebody I would put in airway, and if for a sedation case, not a general anesthetic case where you're insufflating the abdomen for laparoscopic.
Okay, so what are the medications that patients, so they're told not to take anything after midnight. Don't eat or drink anything after midnight, but some people have pills they take in the morning. We usually tell them not to take pills except for like usually, right? Blood pressure.
Yes, that's right. 100%.
What's the recommendation that you give?
Okay. This is my disclaimer. Always talk to your provider because everybody's care is customized. But besides that, I will categorize. If you take your blood pressure medicine in the morning, take it with a sip of water in the morning. There are a few instances, like I think that the angiotensin receptor binding hormone drugs, there is now a trend that people are advised to hold that one. So the losartan, for example, that's a very common ARB. That one can cause really low blood pressure during surgery with anesthesia. And I will say that this is just a trend because when I was in training at a medical school at that time, it was hold your ACE inhibitors, but then they found out, and then they found that did make a difference. So that's kind of the recommendation for blood pressure medicine. Take all your blood pressure medicines the morning of surgery, if that is your usual routine, with a sip of water.
Because the problem is some people don't take it and they show up with a blood pressure of 200 and you have to cancel surgery because that's a dangerous blood pressure to go under anesthesia with.
Yes, right? We want to keep the patient or keep you the same as you were if you were not going to have surgery. So, and now we're taking you from removing if you don't take your blood pressure medicine, your blood pressure is now high. You have the anxiety of surgery and your blood pressure is even more high. And then you go to the surgery center and now you're kind of in a critical situation where like, okay, we cannot just maybe even send you home, not just postpone surgery, but we might not even be able to send you home because your blood pressure is so dangerously high due to the compounding of the rebound blood pressure and anxiety of surgery. So definitely take your blood pressure medicine.
Yeah, just know if your blood pressure is super high the day of surgery, it's going to get canceled for elective surgery. It's just not safe. So what about diabetes?
Yes, for diabetes medicines, the recommendations are just to hold your blood pressure, diabetes medicines the morning of surgery. Hold your diabetes medicines the morning of surgery. And this is presuming that your surgery is like kind of in the morning. If your surgery is kind of later in the afternoon, your fasting guidelines, your medication guidelines probably should be modified to customize it to your care. That is because it's similar to the blood pressure. You don't want your sugars to be too low when you come into surgery, because that can get you into a very critical state with low blood sugars.
Yeah, it's a reverse problem as blood pressure.
It's a reverse problem. So and then also you can get.
But that's if you're on not insulin, but if you're on like metformin or some pills.
Yes, specifically metformin, you can get into this metabolic acidosis.
So you should skip the morning dose. Now, most of us try and be cognizant of diabetic patients and put you earlier in the day so you're not fasting for more than you need to. Because if you just stop eating at midnight and your surgery is not until noon the next day, that's like way too long. Now, if that has not happened and you're diabetic, you should tell your surgeon, listen, I'm diabetic. Can we do my surgery early in the day? And they should be able to accommodate for that's very important, like detail.
Yes, that is extremely, because sugar control, it also kind of dovetails into wound healing. And so if your sugars are way too high, how are you supposed to heal your wound? All those things are they work together. That being said, Dr. Tofa, I just want to make sure, there are so many states, including the state of California, have marijuana legalized. And I wanted to make sure that while we're talking about drugs, that patients feel that it's safe to share with their surgeon and their anesthesia provider any of the medications they're taking. And this is kind of leading into the supplements as well. But we can talk about that next, or we can talk about THC and marijuana if you prefer.
Let's go to the next question, which is exactly that, which is what, because in California for sure, we're like lovers of all types of supplements, herbs
Yes.
and supplements,
Yes.
in addition to marijuana, and also medications. Some things you should actually not take because it will negatively interact with your anesthetic.
Yes. Okay. So, one thing we didn't talk about on the other slide, I'm so sorry before, because I made a note to make sure when you talked to me about blood pressure and diabetes, the other things you kind of want to communicate very clearly with your doctors, like any blood thinners that you're taking, either for cardiac stents, aspirin, or any other NSAIDs, Advil, that type of thing, because obviously those risks of bleeding is increased when you have surgery. But we want to make sure the cardiac stent that you might have is still working. So we have to coordinate care very, very carefully. Okay, that's what I wanted to make sure I said
all
to you
blood
guys.
thinners should be shared, and there should be a plan by your surgeon and your cardiologist or medical doctor as to how to handle that during surgery. And remember, heart before hernia. So I need to make sure I is protected.
I like that.
The hernia comes second. So I'm okay operating on someone on aspirin to protect the heart. Again, I operate on like heart transplant candidates, so that's important. And I'll tolerate a little bit more bruising in your incision because of it. So just understand there's compromises we can make based on what's important to your health and the surgery that you need. Thank you for that.
Okay, so the other supplements, basically anything that you can get at Whole Foods or this other supplement stores, that there's a ton, Amazon even, hair supplements, nail supplements, all those things that are, those should be stopped or should be disclosed to your surgeon before surgery. And the main reason for that is that they can have blood thinning effects. And the ones that I kind of categorize for blood thinning effects are all the ones with the G, like ginkgo, garlic, ginseng, green tea, even saw palmetto can cause some thinning of the blood issues, like
fish oil.
Yes, fish oil. Sorry, those were not under the G's, but those. So, and including the vitamin E's and all the vitamin supplements, those should be stopped before surgery. And I would say at least 2 weeks to make sure it's out of your system and your liver has a chance to recover from those.
Right. Now, people who are daily marijuana users, I've noticed, aren't they a little resistant to anesthesia? Don't you think before?
So now that there are some states that have legalized recreational marijuana, more of the research is coming through to show that. And in one study that they looked at upper endoscopies, they found that patients required a 220% more propofol than somebody who wasn't using THC. And this is a study out of Colorado. And then in terms of like fentanyl, is like 15% and versus 20% more. But in my observation, just my casual giving propofol to somebody who is a recreational, like I would say at least 2 to 3 times a week, marijuana, not so much I would say CBD, but mostly the THC, at least 2 to 3 times the induction dose, and then slightly higher maintenance dose. So you have that one dose to get to sleep, and then you have your cruise control level. So you're at a higher requirement for both of those.
Yeah. Wow. Okay. Well, I think we should go to the fun part of this hour, which is you're a superstar and you played one on TV multiple times. So I was actually watching Shark Tank.
Oh my God, it's so embarrassing.
And saw your episode on it where
so embarrassing.
You were the doctor that was promoting your product because you're an entrepreneur, called Berries, which is available, I believe, for anyone to buy online or at your local pharmacy. Um, so then I got to work with you, and I'm like, I had this eerie feeling like I know this woman.
It's so
And then
embarrassing.
they told me, I was like, I watched that
It's
episode.
so embarrassing. um, it's hard to, I mean, even doing something like this Facebook Live is a little anxiety provoking. And
Oh,
I know it's like your weekly thing, and it's just kind of nerve wracking to see yourself back on Zoom. And I'm like, oh goodness, I'm gonna say something. It's being recorded, and if people can rewind, and it's like, okay, gosh, I look so whatever it is, people will, there'll be trolls out there, you know. So it's that's kind of what I'm afraid of,
but the
people
fact that
trolling.
you applied for it, went through the process, and now have a product that's widely available for everyone to use called Bear Ease. And there's two now, right? You have two products.
Um, they were sold kind of in conjunction with, you know how we had the Tegaderm, the numbing medicine, you put the Tegaderm over it. I was kind of
Yeah.
replicating that system. So it's like the cream itself, and then with the disposable underwear that keeps the cream from moving.
Yeah, it's like medical grade and aesthetic available to anyone without a prescription.
Right. Well, just making it more available to the areas that you need numbing.
Yeah,
So embarrassing.
which is great, which is great. I love that you did that. And then what I didn't know, and I learned after I worked with you, was that you you're married, but you didn't have your children yet, right?
Yeah, that's right. That's right.
Okay, so you decide, you know what? I'm going to do the survivor thing. I'm going to go and
I
be
have a picture
like
actually.
try and
Yeah.
figure out how to
Yes.
survive on an island.
Here's my
What is
survivor picture.
that? How
Um,
long ago was that?
this was in 2011, so I was 36 at the time I got casted. Right now I'm in my mid 40s, and so at the time I was like, oh, okay, it would be great to try to raise some money for my entrepreneurial exercise, and I'd like so that's why I was on Survivor first. But
Oh,
it's just like
really?
any other show; they're trying to cast a variety of people, and I'm sure if they if you wanted to go on Survivor, they would cast you immediately if they were still doing the show.
It would be the only way I could lose that much weight.
No, the problem is that when you get back, they have like a chef that's been trained in like this French school of culinary arts. He
Uh-huh.
cooks you whatever he wants. And then you
Uh-huh.
just and one of the contestants on my season had refeeding syndrome. She got pulmonary edema and she was swollen. She couldn't even, they almost medevaced her out. You go from like starving and all those electrolyte shifts that you have,
Yeah.
and then you get back to your Rice Krispie treats and whatever pancake mix with your syrup, and it's just, you go from nothing to anything you want to eat. This guy literally all he does is cook you whatever you want. And then so I got voted out on, I think I was out of the game day 33. I was sent to Redemption Island on 32. Spoiler alert. I'm sorry. And so I had like one more day of like
Remind
Starvation
me which
Island.
season? Which
And then basically um I was ready to be out of there. But so from those 6 days that I was on Survivor Island, I gained all my weight back,
oh
which
my
is
God.
about 15 pounds.
You lost 15 pounds. Yeah, I saw your
Mm-hmm.
pictures. It's pretty devastating how much weight you lost.
I was like, I could put my hand like this around my arm,
Oh
like
my,
this. I'm like, I can't.
so
I was
not
so.
healthy for you.
It was like I was like amenorrheic for 2 months, and I had my hair started falling out. It was really really bad. Like I had some pictures of later in the season. It was like I was like day, because I got recruited very short. I had like only 2 weeks to like bulk up or um
Oh,
carb load or whatever. But
yeah.
like I had like 6 8 pack abs, but I was like, my hair was falling
Oh, wow. So did you make enough money to be able to help that spark your entrepreneurial
out.
endeavor?
So
Was it worth
I
it?
made I made what I would have made as an anesthesiologist had I stayed at home pushing
Ah!
propofol. Because what you don't know is like you get reward, your reward or whatever your prize money is based on your elimination sequence. So the first person who gets eliminated gets $2,500, but you're gone the whole time. So you can't, they send you to like the first 6 people that were eliminated, they were sent to Fiji, and they were on vacation for a total of like those 40 days. But they didn't want them to know the elimination sequence.
Right, right,
So
right. Wow. Crazy.
and I it was really rough. I would say that parenthood is more rough than Survivor in some regards, because it's like relentless. You can never escape your children. And at least Survivor, there's only 39 days max. Your children are forever.
That's too
And
funny. And you,
but
for those of you that want to follow her, she does have a fan page on
oh, you're so
Facebook.
funny.
There's a
Totally
Dr.
forgot about that.
Fan page with hundreds and hundreds of members. So I am your fan, but not specifically for Survivor. I just
I
want
am
to.
your fan. I think you don't realize how much I admire you, and it's like I'm fangirling you because you've really built an amazing practice and you have an amazing team. And I sound so hokey whenever I post about how much I like going to work, but it is so true. I like going to work because I get to work with people like you.
I do have a fantastic team, and until I opened up my own hernia center, I didn't really have a team. I was like a surgeon that works within a hospital setting. And my team was like the entire department of surgery, like residents and students. But I didn't have like a dedicated clinical care team. And this is the first time that I can say I have a team, and it's like, it's worth a lot. On that note, my team, the Dodgers, are playing tonight. I hope they win.
Oh, yes, this is getting close to the end.
It is. So, okay. Thank you for your time. We all have to go
Thank
watch
you.
our World Series game. Go
Well,
Dodgers.
I appreciate the privilege.
Thank you, Dr. Ma. This is me, Dr. Shirin Tofai, signing out. You can follow me on @HerniaDoc on Twitter and Instagram, and on Facebook @Dr. Tofai. I will post this for all of you to share and rewatch on my YouTube channel. Please follow Dr. Edna Ma on Facebook and go watch her Survivor.
No, don't watch it. It's embarrassing. Thank you, Dr. Tofai.
You're welcome. Thanks for your time. Appreciate everyone for logging in and participating. See you all next week. Bye-bye.